Our first speaker, Adrienne Vazquez-Guerra from the University of Miami Sylvester Comprehensive Cancer Center, will be speaking on how to address fertility in young women diagnosed with cancer and oncofertility in cancer survivors. Welcome, Adrienne.
Good afternoon, everybody. Thank you so much to the conference directors and to the planning committee for the invitation to present, and obviously to our colleagues in pharma and to all of you for attending. So without any further ado, I'll get started. My name is Adrienne Vazquez-Guerra. As introduced, I'm a nurse practitioner at the University of Miami, and I've been doing cancer survivorship since 2016. I do oversee the daily operations of our clinic, and I oversee the training of the different nurse practitioners and APPs and PAs. And I also work collaboratively. I just want to start by saying we at UM adhere to the NCI definition of a cancer survivor, and that's really from diagnosis throughout the continuum of their life. And that's really important because fertility, which is what I'm going to be presenting on today, is a survivorship issue, and it starts at diagnosis. It's never too late, but it really needs something, one of the most important things that needs to be discussed with anyone of childbearing age from diagnosis. This is not too late. Once the patient's in the hospital, has already lost hair, is already on treatment, it's not too late. It's still something that needs to be addressed. So I really want to impart that even at survivorship, what people think of as at the end of treatment, it's still not too late. But we want to make sure that we address this and that it's not forgotten. It is a huge issue for patients, and it's one that we are responsible from nursing to APPs to physicians. And there's plenty of standards and research and NCCN guidelines on that importance, from NCCN, to ASCO, to the Oncology Nursing Society. All of them have statements and guidelines with different recommendations. And basically the experts do say, consensus, that we need to address this with anyone. For children, obviously, it's to the parents, but adolescents, young adults, and all cancer survivors of reproductive age, this is a topic that needs to be part of their key part of their care. These are the guidelines, if you haven't seen them. I'm sure many of us are familiar with the guidelines in terms of different diseases and the treatments that we give patients, right? And what's recommended and what's approved. But there's a lot of survivorship guidelines as well. And if you haven't looked at them, I encourage you to look at them. So anything from fertility planning to smoking cessation. But here in fertility, it goes into detail on some of the different approved procedures that are recommended. Again, for males and females, this presentation is looking primarily at females, and what are the different things we can do for them. So some of the recommendations, ASCO, again, has position statements where they all basically say the same thing. We need to do something, and this needs to be addressed with patients. The Oncology Nursing Society also has a joint position statement where they are very adamant about oncology nurses and APPs. This is part of our roles and our responsibilities with patients, to talk to patients, to see if they're interested in fertility preservation, and if they are, making sure that they're referred to the appropriate resources to have this addressed. We want to look at their risks. We want to educate them about, what are the risks of infertility, confirm their understanding, and making sure that other loved ones or parents are involved in that conversation, and then providing referrals to specialists or fertility preservation services. So what are the guidelines? They're all pretty much aligned. Like I mentioned, fertility risk should be discussed as early as possible, and I would say diagnosis. Right, when you're talking about treatments and what are the next steps, we need to have this conversation so that if there is something that we need to do for that patient, we have enough time. And time is key. We don't always have enough time, right? So we want to talk about it prior to treatment initiation, refer them to reproductive specialists when appropriate, re-refer after each new treatment, and make sure that there's nothing that we're missing, right? Maybe for the first treatment, it wasn't something that was going to be toxic or cause any harm to them, but maybe the second treatment is. So we want to make sure that we're collaborating with those specialists to make sure that nothing is falling through the cracks. Documentation, which I think we all know, document it, because a lot of times, and I'll say I see it often in my patients post-treatment in survivorship, nobody talked to me about it. I don't remember them ever telling me. I don't remember ever being referred. I don't remember being called to make that appointment. So it's really important that we document it. first of all, for our own license, but then also for the patients so that they know as well. And then again, that discussion at the end of treatment. So recently I had a patient, a young patient, he was treated as a child at Sylvester in Alex's place, which is our pediatric clinic. And he was now 18 years old, coming to his visits by himself, and was transferred to my survivorship clinic as an adult. So this was his first time being seen kind of independently. And I talked to him about it. I brought it up right away. I said, you know, have you ever talked to anyone about fertility? I know you were young when you were treated. Maybe your parents were involved. And he said, you know I did sperm banking, but I don't think we could afford it back then to keep basically the payments every year to hold the sperm. So I don't know what happened. I don't know where it is. It was done here at UM. His parents weren't at the visit, and I said, you know, this is an opportunity. Regardless, I think it's time to re-refer you. Maybe you're not planning on having children today, but we can look into the resources and what happened when you were a child and you were diagnosed and treated. Where is that sample, if it's still around? And if not, maybe we can retest you and see where you're at today and what options there are, maybe for the future if something needs to be done. And he was open to that. So a very mature 18-year-old, as many of our cancer survivors are. So why does this matter from a clinical perspective? Again, there's lots of articles, you know, in ASCO, but basically a lot of patients say that this is a significant part that really impacts their quality of life. It can oftentimes impact their treatment decisions, right, on what type of treatment they may want or the timing of the treatment they want, and long-term psychosocial well-being. About 50% of reproductive age women with cancer report that they were never told about their infertility risks or their preservation options. So again, really important for us to document those conversations with the patient. And lack of counseling is linked to increased decision regret and distress post-treatment, okay? So who's most at risk? High-risk populations are really adolescent and young adults and perimenopausal women. Any patients receiving alkylating agents, radiation to the pelvic or abdominal area, stem cell transplant patients, and oophorectomy patients. So mechanisms of treatment of related infertility, I mean, this is just obviously high level, but you know, obviously there's chemotherapies that can affect. Any type of treatment can affect depending on the treatment and on the type of modality that's being given. Radiation, depending where the radiation is being given. Surgery, obviously, if that patient's having an anatomic loss of anything that would involve that area. And endocrine therapy. So what options do we have at diagnosis? And there's some established diagnosis that NCCN defines for us. So established options are embryo cryopreservation, all right? And it's the most established with the highest cumulative live birth rates and data that we have. This does take ovarian stimulation, which takes time. So that's why it's really important to have these conversations with the patients and know the timing and the importance of that patient's situation, because that may make a difference whether this is an option for that patient or not. It does require a sperm source. So again, looking not only at your patient's time to when they need to start treatment, but where are they today? Do they have a partner? Are they a young adolescent? That's not an option, right? So you have to look at each of the different modalities and see which one's most appropriate for the patient. The second one we have is oocyte cryopreservation. So it is considered a standard of care now. It's no longer considered experimental. Similar stimulation time, 10 to 14 days. It does not require sperm, and it's very commonly used in our AYA population. And I'm bringing this up just so you have an idea of what are the different established options for patients, but these go into much more detail with one of our fertility specialists. And then the third established option is ovarian tissue cryopreservation. And that's the surgical removal and freezing of the ovarian cortex. Particularly useful when you're having urgent chemotherapy that needs to be started quickly, or patients that are pre-pubertal. And actually, it's the only option in this population. Increased live birth data, and actually they've recently looked at that data and kind of redefined it. So it is actually now an established where it wasn't before. And as it says there, in many centers. Other options, okay? So these are other options, but they're more situational depending on the patient. And it really depends, again, on their hormone status, their age, fertility sparing, surgical approaches. So things to be considered, but the first three that I mentioned are the established options that we would want to try to use if appropriate. As I mentioned, key considerations, time sensitivity, right? The urgency of that patient and their treatment, hormone-sensitive cancers, age and ovarian reserve, especially if you're comparing a very young patient or a much older patient, cost and access, which is still an issue everywhere, and patient values. So how do you make it work? And these are different interesting thoughts, right? Because this all sounds great and we're gonna refer them, but a lot of conversations that I have with providers is like, I wanna do it, I just forget. Or it is important and I did do it, but then the order didn't get followed through on, or whatever the case is. And again, it really falls on us to make sure that this happens. So for those of us who have an EMR, right, an electronic medical record, which not all of us do, but for those of us who do have it, a BPA, which is a best practice advisory, and this is a best practice. I learned recently that OPAs are not necessarily based on best practice, and they're also alerts that pop up in our computer and friendly reminders. But this best practice alert is built into the EMR, and in our institution we have this, it was confirmed. But basically, it fires when a patient is within reproductive age, they have a new cancer diagnosis, and some type of gonadotropic or some type of treatment that may affect their fertility is ordered, okay? The provider then has the option to pause, have that conversation with the patient if it hadn't been done already, and then place the referral as appropriate, and then we document away. So this is actually probably one of the more gold standards, I'd say. It's what we have in our practice at University of Miami. Other option is an opt-out, okay? And this might be ideal in maybe a clinic that sees maybe younger patients, or a very unique cliche clinic that just sees AYA patients, for example, adolescent and young adults, where most of these patients need to have this conversation, and really probably most of them are gonna be referred. But it basically automatically refers any patient that fits that criteria. So age, chemotherapy, new cancer diagnosis. In conversations with other colleagues, if it's not in that right population, it really becomes a burden, because you have these conversations with maybe older patients and they're done having children, or they don't want to have children. So then you're kind of having to work backwards and pull back the referral, or have the patient explain, no, I'm not interested, and that kind of leads to some patient dissatisfaction. So I think ideally, if this is in the right population, it serves a great purpose. And then standing order sets that include fertility preservation. So this could be in an EMR, but it could also be in a paper, charting system. So if you have some type of system where maybe for new patients, that they're gonna get a CBC, a CMP, tumor markers, CAT scan, PET scan, whatever they might need, fertility preservation is one of those options as well. So if it's in the EMR, you can either build it yourself with the help of IT, or you can also, some of them have them built into their system. So automatically for a new breast cancer patient, it's gonna be built into these standing order sets. If you're doing it on paper, and I always say that, kind of make your own, just make your own and see what works, and then from there, have someone follow up on those referrals and orders. Partnerships, so important, So I love that we have different presenters here today, but partnerships with our different colleagues, and in this case, in reproductive endocrinology, are really important. So obviously, we work in an institution where we have someone in-house, but if you don't, find out who are the people in your community that you can refer to that feel comfortable treating these patients, having conversations with these patients, and knowing the urgency, which I think is most important. Maybe a healthy young male or female who's going to see a fertility specialist may not have the same urgency, but when they know they're getting a referral from you, they know that it's important, and these are the key things that we need to look at for this patient. So priority slots, same week consults, those collaborations and conversations with our colleagues are really important. And then some other ideas, right? Education, which we're all here for that today. So education and accountability at the provider level. Financial navigation and advocacy programs. There's so many programs and organizations in the community. Many survivors who have a vested interest in making sure that this is addressed with patients at every visit. So partnering with them and looking at the resources they have and working together. Standardized fertility counseling scripts and smart phrases, something that we've also developed. So, again, if you have that EMR, just a little dot phrase, so that automatically goes into your note and you make sure that you're documenting it appropriately. If you're doing it on paper, then writing it out and making sure that you have maybe a standard script that you want to use. And then embedded oncofertility navigators. I mean, this is ideal world, right? If we had an actual navigator who could help with any referrals that come in and making sure that patients are being followed up on, that the referrals are placed, did they make it to their appointment, what's the next step? That would be the gold standard, but we know that that's not always possible in all different practices. So fertility and cancer survivors, right? And when I say survivorship, right, post-treatment survivorship, it does not mean that the fertility issues have been resolved, as I mentioned with my young patient that I saw recently. So many, and I see them in my clinic, and I treat thoracic oncology and lymphoma patients. My lymphoma patients tend to be a lot younger, but they come with the questions, can I still conceive? When can I conceive? Huge question that I get. And actually the NCCN does have a statement that they say at about 2 years post-treatment, depending on the treatment, is kind of like the benchmark. Is pregnancy safe now? When will cancer recur? So even if the patients aren't maybe asking it at every visit, these are thoughts that they have, and they do come to us in our survivorship clinic and ask about it. So, I mean, this is an example, but, making sure that we have open discussion with our patients about it, not only in the clinics, in the infusion centers, in survivorship, but basically just opening it up, open-ended questions. Some cancer treatments can affect fertility. I don't know yet. This would be in the example of at diagnosis. I don't know yet what it means for you, but it's important we talk about it and let's see what treatment options we have. And I think patients are usually pretty open to hearing that, at least, right? If you open up the door, they're usually going to talk about this because it is. I think sexuality, right, and function, and then fertility are two big topics that we need to make sure that we're having those conversations with our patients. So in summary, fertility counseling is considered a standard of oncology care. Uncertainty in the patient still requires a conversation, okay? Maybe not a referral if they're not ready, but maybe they don't have time to be ready. So making sure that we have that conversation and following through on their requests. Survivorship is not too late. Utilizing technology, if you're able to, is really helpful. And multidisciplinary teams do improve outcomes and working together. So thank you very much. I look forward to your questions.
The Medical Educator Consortium delivers a comprehensive set of podcast episodes that draw back the curtain on cancer research and care for the cancer patient. Top key oncology leaders will lend their expertise and provide up-to-date topics on drug developments, research, diagnostic, and treatment approaches for the ever-changing oncology landscape. Each episode will welcome an expert guest who will guide the listener through specific disease states of interest, from the many stages of cancer research and drug development, early discovery efforts, to current available clinical trials and drug approvals. Staying up to date will be the key for better outcomes. Stay tuned for more episodes coming soon, and visit our educational website at www.mymedflix.com. The Medical Educator Consortium, bringing global education within our reach.